Slow on the trigger, Casey. Good morning, everybody. Can you hear me? Okay, thanks. Well, I'm happy you're able to join us both on Zoom and here in person on this lovely, sunny, early spring day in Ann Arbor for another presentation, in this case, the Distinguished Lecture Series, monthly lecture series lecture at the Osher Lifelong Learning Institute at U of M. My name's Craig Ramsey. I'm a volunteer, and I will be the moderator today. The moderator amounts to first giving some instructions about how we're going to do Q&A, also make some announcements related to upcoming events at OLLI. Then I will have the speaker for today introduced. I'll introduce the introducer, and then I'll be at the laptop over here, as a lot of you have known who've been here. I will be looking at questions coming in on the Q&A function of Zoom, and also there'll be two mic assistants out in the aisles who will be collecting the 3x5 cards. If you didn't get one, we can get those to you. Just raise your hand. You can write a question on there, and that will go to the mic assistant, who will then take it from there to get the question to the speaker in the Q&A session. For those of you on Zoom who by now haven't used it enough to know how to get out of a glitch that might be going on, by 3 years into the pandemic, kind of hard to believe. People haven't used Zoom at this point, but I don't want to assume that. If you're having a difficulty, a frozen screen or some other technical issue with a good reception on Zoom, you can simply leave the session, and I would suggest you go back in with the link that you went in with to begin with. That usually will take care of the issue if you're at home on Zoom. If you're having more difficulty than that, you can put a message in the chat, and I'll try to take a look at that if something pops up on it and try to get to you with some assistance if leaving and coming back in doesn't work out. As far as upcoming events, tomorrow night, this Wednesday, April 12th, there will be a Evenings with OLLI presentation at the Kellogg Eye Center. And it's entitled Leaders and Legacies. The Underground Railroad Laid Tracks in Ann Arbor and Washtenaw County. There will be two presenters who are associated with the African American Cultural and Historical Museum on Pontiac Trail in Ann Arbor. Beginning at 5:30, the recent trend has been they will hold a light refreshment, beverages and refreshments at 5:30, and then at 6, the presentation about the Underground Railroad in Washtenaw County in Ann Arbor will begin. Two people associated with the museum are very experienced. One of them, Deborah Meadows, actually led an OLLI out-of-town tour of southern Michigan Underground Railroad sites a couple of years ago, if I recall. So if you haven't already signed up for that, it's a $10 fee to go tomorrow night. 5:30, freshmen, 6 for the presentation. So I'd encourage you to go. I think it ought to be a pretty eye-opening presentation on how Ann Arbor and Washtenaw County played a role in the Underground Railroad. And then this Thursday, second announcement at the usual 10 o'clock in this auditorium and on Zoom, there will be the first in the 6-part series on human migration through the ages, as the series is titled. So look forward to that, kicking off the last 6-part series for this year. So now my obligatory disclaimer. It is now, the views expressed by the presenter are not necessarily the views of the University of Michigan or the Osher Lifelong Learning Institute. Without further ado, I must admit, I saw that John Kelly, who was supposed to be the introducer today, but I have not seen him at this point. Is anyone from the committee here able to introduce? Jim, can you just give me that? Sorry for the little glitch here. The speaker today will be speaking under the topic title, Expanding the Science of Firearm Injury Prevention, a Pathway Forward for Reducing Death and Injury in the United States. The speaker is Dr. Patrick Carter. He's an associate professor of emergency medicine at the School of Medicine at the University of Michigan, and he's in the Health Behavior and Health Education section of the School of Public Health at the University of Michigan. He's currently directing a Centers for Disease Control funded University of Michigan Injury Prevention Center grants to do that work. And he's part of the leadership team also funded by a federal agency on firearm safety among children and teens. It's a consortium that's dealing with that. Dr. Carter's research is within the field of firearm injury prevention, specifically the development, testing, and implementation of emergency department-based interventions to decrease firearm violence among youth particularly. So without further ado, I give you Dr. Carter.
Good morning. Can everyone hear me okay? Great. Okay. Well, thank you so much for having me here today, and to all those on Zoom. I'll be talking about the science of firearm injury prevention and talking a little bit about how we in sort of the research space and public health space think about approaching this as a public health problem. And I'll talk a little bit about what we're doing at the University of Michigan also in this area. So objectives for the discussion today are really around talking a little bit about the problem here in the United States and how we think about approaching this as a public health problem and a science problem, and what we know so far that works, and sort of where we're going in terms of future work to try and prevent these types of deaths and injury. So I always start when I talk about firearm injury by talking about what we mean when we talk about firearm injury. So firearm injury means everything from a child who finds an unsecured firearm to youth who are involved in lower level fighting that escalates to lethal violence that involves firearms, to school shootings, to intimate partner violence, to older adult suicides, to mass shootings and police shootings. And so as I talk today about how we're thinking about this problem and how we think about approaching this from a scientific lens, I'm talking about all of these things. And the framework that I will talk about has applicability across all the types of firearm injury. And sort of think about this in the same way we think about other medical or health issues. If we were to talk about cancer, we would talk about multiple different types of cancer and how we approach each of those with a similar framework, but specific solutions that are tailored to the problem. And so as we talk about firearm injury, same type of approach. I also think it's important, I say there's really only maybe one other issue in the country that's more controversial than studying the issue of firearm injuries and deaths, and that's reproductive health. But as we approach this public health problem, it's important to recognize that people come to this with their own viewpoints and their own lenses, but if we really focus on the importance of how we reduce death and injury, we can find common ground, and we can bring in the perspectives of all of those people who come to this issue and incorporate that as part of the solutions. And we really are focused on that as a common goal, and really not on the political aspects of this issue. So again, the lens that I take is that this is a public health disease similar to all the other public health diseases that we have approached, addressed, and applied the science of prevention to. So as we think about how we have prevented motor vehicle crashes and head injuries from people who ride bicycles and motorcycles to how we address the public health problem of cigarette smoking, we've taken this prevention lens, and that's the approach that I will take today, and that's my framework for how we solve this. And it's similar to all of these other public health diseases and issues that we've approached. And I particularly like this quote from David Satcher, who was the Surgeon General in 1993. As people think about whether or not firearm injury and death is really a public health issue, if it's not a health issue, why are people dying from it? And what we know in the United States is that people are dying from firearm injuries. So here on this graph, you can see both a red line and a black line. The black line is motor vehicle crash injury and death, which for a long time was a leading cause of injury-related death in the United States. And the red line is firearm injuries. And you can see we've had a steady increase in firearm injury and death over the past several years, actually since the mid-2000s. To the point now where annually we have more than 45,000 people in the United States die every year from firearms. That's the highest absolute number of firearm deaths we've ever had. Over half of those deaths are suicide, a little under half are homicides. We've seen a 30% rise since 2014. And in 2017, nationally across all age groups, we saw that firearm injury surpassed motor vehicle crash injury. And you'll hear me come back to this analogy throughout the talk today, but the story of these two types of injuries is really as much about the success of how we've approached and addressed the problem of motor vehicle crash injury as it is about the failure to address the problem of firearm injuries. Michigan looks just the same as the rest of the country, and we've seen that firearm injury and death across the state of Michigan has increased. And I particularly like this graph because it emphasizes another key point I'll make is that firearm injuries affect all of the communities that we live in. This is not a problem of urban America. This is not a problem of rural America. It's not a problem that is in suburban America. It's a problem across all of our communities. And so as we think about the solutions, we have to think about what those solutions are across all the types of communities that we live in. While it affects everybody in the United States, there are certain populations and certain age categories where firearm injuries are more common. And we do see, you can see here the purple line, I think that's the color, is overall firearm injury and death. And you start to see a real significant increase in the adolescent teen years, such that firearm injuries are now the leading cause of death among children and teens in the United States. And then a slow, sort of steady decline throughout the early adult years until it levels off for most of adulthood, and then a significant increase in older adults in firearm deaths. Now, the drivers of those peaks that we see in firearm deaths are different. So among early adolescent years, homicide is a much bigger driver of the deaths that we see, although suicide is a significant component. And in the older adult population, we see a very steep rise in firearm suicides. The numbers that are underlying this, and we'll talk a little bit about some specific populations that don't come out in these graphs, are, among our active duty military and veteran population, who already have an overall 50% higher suicide rate than the general US population. About 70% of those deaths are due to firearms. So I particularly want to highlight the problem among adolescents and youth who are at the highest risk for firearm death. And you can just see here in the figures that for 1 out of every 4 deaths that occurs among youth in this country, it's due to a firearm, either firearm homicides or firearm suicides. And you can see that suicide really emerges in the teenage years. Homicide is a particular problem throughout all of child and adolescence. And when people talk about child deaths due to homicide and firearms, largely we're talking about intimate partner violence, and intimate partner violence going on in the home where somebody kills usually a female partner and the children who are in the home. And so those are the deaths that are occurring largely in that younger age group population. And speaking of intimate partner violence, that's another group that doesn't really come through in the initial graphs that I showed you, but we have a significant problem in the United States with intimate partner violence, both for men and women. Almost a quarter of all women suffer from intimate partner violence at some point in their lifetime, and about 14% of men. And more than half of intimate partner homicides that occur are firearm related. And we know that firearms increase the risk of a lethal outcome in an altercation by 5 times when a firearm is in the home. Certain populations are at increased risk, so we know women are at increased risk, especially when they're pregnant. Underrepresented minority populations, people with disability, and LGBTQ populations are at increased risk for firearm injuries due to intimate partner violence. The third population I'd like to highlight is older adults, and I already sort of highlighted this, which is we see this sudden increase in suicides among older adult populations. And we know the drivers of suicide for older adults look different than the drivers of suicide for adolescents. We know that older adults suffer from some unique issues around their partner or their spouse passing away, and isolation, especially in our rural communities, and easy access to firearms, depression and cognitive decline that can increase risk with firearms. And so there are some unique issues there that as we think about the solutions for how we address the problem of firearm injury among this population, we have to think about also the unique drivers that will lead to the tailored solutions that we need. So you can't talk about firearm injury and death without talking about race. There are significant disparities in who dies in the United States by firearm injury. So African American, especially African American youth, and particularly African American male youth, have a significantly higher rate of death due to firearm injuries than any other population. And that's largely driven by firearm homicides or interpersonal violence, but that's not the only disparity you see on this slide. We also know that Native Americans and Alaskan Natives die at significantly higher rates from firearm suicide, driven by firearm availability in those communities and underlying poor access to mental health treatment. And we know that among white Americans, suicide has a significant impact. And so as we think about how we approach this problem, we also have to think about that there are underlying structural issues that drive some of the outcomes that we see among particular populations. And I would encourage folks who are interested in learning more about what I can present here in a brief talk, you know, the legacy of redlining and segregation and racism and its impact on the outcomes we see here on this slide are significant. And there's a whole book called The Color of Law that talks a lot about how redlining contributed to elevated rates of poverty and structural disadvantage, especially among African American communities, and the legacy of that and the impact of that on especially interpersonal violence outcomes. As I highlighted earlier, firearm death and injury is a problem across all of our communities, so it's a problem across our rural settings, our urban settings, and our suburban settings. And in fact, if you look just at the data alone, the rates between those different types of communities are actually fairly similar. The drivers of what causes deaths in those communities is different. So we see more suicides and unintentional firearm injuries in our rural settings, and we see more homicides and interpersonal violence in our urban settings. But overall, again, as I said earlier, this is a problem that impacts all of our communities. And the same thing we see in the national data, we see mirrored in our Michigan data here. So I've talked pretty much up to this point about what we know about in terms of data for firearm deaths. Also helpful to understand those firearm injuries that don't immediately cause death but end up in hospital settings. And as I talk about how we approach this from a research angle, this is a particular problem because we lack good data on how many people are shot in the United States every year. And that's because we collect death data on every person who dies in the United States, but we actually don't collect hospital data at any kind of aggregate level. So as we look across all of our communities in the United States, we're not able to tell you annually how many people have a firearm injury. We have rough approximates. We think about 70,000 people, and we think that number is increasing. But again, the data is not very good. And so I tell people to imagine this was 2020 and we were standing up here and not able to tell you how many people had COVID. So if we think about where we need to invest in terms of addressing this as a research problem, having better data on how many people have a firearm injury every year in the United States is really critical to how we direct our public health resources and investment to help solve this problem. So those people who survive an immediate firearm injury have significantly higher rates of long-term consequences. They have a higher rate of repeat violent injuries if the original firearm injury was due to interpersonal violence. They have long-term rates of disability, so over 50% of kids who are injured with a firearm injury and make it to the time of hospital discharge have some type of long-term disability that they live with the rest of their lives. And 20% of those injuries among kids are to brain or spinal cord, so they have significant disability and care needs that are quite costly for the rest of their lives. That's just the physical aspects. There's also the mental health aspects, including elevated rates of PTSD, anxiety, and depression among those who suffer a firearm injury, higher rates of developing substance use disorders, repeat violence and violent injury and recurrent firearm injuries. And then for those that are due to interpersonal violence, elevated rates of being involved in the criminal justice system, which carries its own higher risk of mortality in addition to that occurs as a result of firearm injuries. And involvement in the criminal justice system leads to delayed family formation, employment opportunities, a whole host of higher risk factors that increase the risk for negative outcomes and basically getting stuck in this cycle of violence that doesn't allow people to exit and lead productive, healthy lives. The main risk factor for firearm injury, I could give you a whole separate talk about what are the risk factors and protective factors for firearm injury, but the one I want to highlight the most is easy and ability to access firearms by people who shouldn't have them at high-risk times. So we know that, as I already said, women are 5 times more likely to be murdered by an intimate partner when that partner has access to a firearm. We know that in 75% of school shootings that occur, the firearm was acquired from the student's home or the home of a family member or relative. It wasn't secured safely. For suicide risk, we know that firearm availability in the home increases suicide risk by nearly 5 times. And then if that firearm is loaded in the home, there's 9 times as likely to be a fatal outcome in that home. So the take-home point really here is firearm access by high-risk individuals during high-risk time periods, moments of crisis, either crisis that will be externally manifested or internally manifested, is the single biggest modifiable risk factor for firearm injury. That's regardless of intent, meaning suicide, homicide, and it's regardless of population. And so as we think about solutions, that has to be a part of what we discuss in the solutions. And we know that US firearm ownership is increasing. So in 2015, this data is actually getting a little bit old. The last estimate we have is that about 265 million firearms were in circulation in the United States. About almost a quarter of US adults owned firearms, split pretty evenly between handguns and long guns, but those folks who owned firearms owned multiple firearms, so an average of 5 per owner. And we've seen this trend over time that a smaller proportion of the population is owning more and more firearms. We also see that production of US firearms is both increasing and changing in interesting ways. And so we've seen the steady increase in the types of firearms that are being produced by the industry, and we've seen a shift away from revolvers to pistols and from simple rifles to more high-powered rifles and higher caliber weapons. And so here you can see, this is just for handguns, but you can see an increase in the caliber of the pistols that are being produced by US firearm manufacturers. And that translates to what we're seeing both in crime trace data, and I'll show you in a minute, in healthcare data. But in crime trace data, the types of handguns that are being recovered from crime scenes are higher caliber weapons than what we used to see. And that's translating into differences in injury patterns. So what you can see here is this is what's called an injury severity score. It's basically a measure of how severely somebody is injured, a standardized measure that we can do in a hospital setting. And what you're seeing is year over year from firearm injuries, we're seeing this steady increase in the severity of the types of gunshot wounds, firearm injuries that we're seeing among populations. And that's across all ages, although there are some differences. We're seeing increases particularly among young people and older adults. Again, the population is most severely impacted by firearm injuries in the first place. This is likely both a manifestation of this change that we're seeing in the types of firearms that are out there in circulation, but also our ability to get more people from a scene of a firearm injury to the hospital. So it's a combination of two different things, but certainly an impact of the changing nature of the types of firearms that are in circulation. And here you can just see an example from a single trauma center where we're seeing increases in the higher caliber weapon wounds and a decrease in the smaller caliber weapon wounds. And all of this has both a human toll but also an economic toll. And as we think about the total cost of firearm injuries to the US economy, that can be measured in dollars. And so this estimate actually now is getting a few years old, but the last estimate was around $230 billion annually cost to the US economy. About $9 billion of that is in direct medical care that gets provided, and the remainder is indirect costs. So the costs of lost work and productivity from people who are disabled for the remainder of their life, lost quality of life, criminal justice proceedings, legal proceedings, jail time, all of those have a cost to them, and that can be measured. And so the estimate currently is $230 billion. And if you look at that compared to other diseases and healthcare issues that we have in this country, you can see it falls squarely in the middle between the cost for addressing the problem of obesity and how much we spend every year annually for Medicaid. So I'm going to shift gears now and talk a little bit. I've talked all about sort of the problem writ large, but I'm going to shift and talk a little bit about how do we think about approaching this? How do we approach this from a scientific and a public health lens? And really the way we do this is the same as we do for any other scientific or medical or public health problem. You know, we work to define the problem, a lot of which is what I just presented you for data. We identify what are the risk factors for the disease, what are the protective factors that protect against the disease. We develop and we test prevention strategies. We work to implement those, and we monitor them and develop better ones. And the other way to think about this is data that drives our understanding of the disease and our understanding of the solutions, and that generates knowledge that can be applied in terms of action. When we think about how we solve this, there are problems at every level of what we call the socio-ecological spectrum, which means that there isn't a single solution to this problem. Often when I hear people talk about this, they say, well, if this law were just clearly in place, or this program were clearly in place, or if mental health was solved, that would solve this problem. But it really isn't about any single one of those things. It's about how we apply all of those things. There are solutions to this problem that are one-on-one with individuals that can be applied through healthcare settings, through school settings, through parent and child interactions and education. There are things that can be applied through our social settings, how we engage with other people, mentoring programs, and other such solutions. There are things that we can do at the community level, and then there are things we can do at a public policy level. And it's really not about a single one of those, it's about the totality of all of those. And I will talk about different aspects of this puzzle, but it's really about putting all those pieces together in a single puzzle to help solve this problem. And we've done this. So I'll come back to this analogy, which is with motor vehicle crash injury. And you can see here, this is a picture of a car crash from the 1950s. You would not see this type of car crash today. Why would you not see it? Because you wouldn't see a post this close to a road without a guardrail. You would not see a car collapse in this way, where basically the engine ended up into the driver's cabin. You would see EMS trucks there at the scene of the crash to get people to treatment. You would see that the driver was wearing a seatbelt. You would see that the car had a collapsible front steering column so that the steering wheel didn't drive through the driver's chest. There are solutions across all of the part of the framework I'm going to talk about in a minute to help solve this problem that we've done effectively in the area of motor vehicle crash prevention. So you can see here is just an example. There are engineering solutions, things that we've done to our vehicles, to our roads, to improve the safety of the vehicle, to improve the safety of our roads. There are individual level behavioral solutions. We have changed the culture in this country around drinking and driving monumentally. And if you think back to the 1950s, it used to be have another drink before you hit the road, and that type of comment today would be unacceptable in a social setting. We have put in place minimum drinking age laws for not tolerated underage drinking and driving. We have developed better trauma systems to respond to car crashes, and we've increased measures for populations that are at elevated risk. So for children, we've built car seats. The picture I had in the first slide was of a kid standing up in a little cage. We don't have car seats like that anymore. We've developed ways of training new drivers because we know that that 16-year-old who's on the road in the first 6 months as they drive is the highest risk driver out on the road. And we know that that's a high-risk time for car crashes. So we've developed graduated driver's licensing laws so that we train them in stages and that they go out and they have increasing levels of risk before they start driving their cars. For our older adults, we have physician review and intervention for elderly drivers. For folks who have had issues with alcohol and driving, we have measures we've put in place to prevent them from driving in vehicles drunk. So how did this all come about for crashes? Because I think it's useful to think about this for that area of injury. We've had great success and apply those same principles to the area of firearm injury. So William Haddon was the sort of the father of injury science or injury epidemiology. He was the first head of the National Highway Traffic Safety Administration and eventually the Insurance Institute for Highway Safety. And he developed this idea of the Hayden matrix. You know, in the early 1950s, as we started to see these high rates of motor vehicle crash deaths, what we saw was that people primarily said, well, this is just a problem of bad drivers. If we improved how people were driving, there wouldn't be any crashes. And what Dr. Haddon said was, no, let's think about this as more than a problem of just the driver. Let's think about this as a problem of the driver's behavior, of the vehicle that they're involved in, of the physical environment that surrounds them, of the social environment in which they're operating. And let's think about all the things that are occurring before the crash, all the things that happened at the time of the crash, and all the things that happen after the crash. And if we come up with that as a framework, we can start to identify the problems in each of these boxes and then the countermeasures in each of these boxes. And the success we've had with motor vehicle crash injury, which is a 76% decline in motor vehicle crash deaths since the mid-1950s, has been due to all of those factors and all of those boxes and approaching all of those problems. And we can do the same thing for firearm injury. So as we think about how we approach this problem, it's really a question of how in time and space and where do a person with a firearm and a person who's at risk to be a victim of a firearm injury come together? What are the risk factors for those events? What's occurring before? What's the social and physical environment surrounding them? And then what are the outcomes there and how do we deal with the issues after the event? And so if we start to think about it with that framework, it becomes more of a problem of how we address all of these factors than a problem of how do we address specifically just the firearm. So I'm going to shift gears a little bit and talk about some of the things we know work. So I told you up front at the top that the single biggest risk factor for firearm injury was really firearm access by people who shouldn't have access to a firearm, and at times they shouldn't have access to a firearm. And so the single biggest countermeasure we have right now to that problem is locking firearms in homes. So we know 76% of school shooters got the firearm from the home. We know that almost 75% of those adolescents who go on to commit firearm suicide got the firearm from their home or the home of a relative. And if those firearms were not accessible, that would be a part of that puzzle of solutions. And so when we talk about locked storage, what do we mean? We mean a gun safe or a locked box with the ammunition stored separately. And there are various types of firearm locks out there. You can see the picture on the left is of a trigger lock, and then in the middle is a cable lock, and then probably the thing that's most popular, especially among firearm owners, is a gun safe, and you can see that at the right. So it's important as we think about locked firearm storage and making sure firearms are stored safely, that we don't just consider what's going on in your own home, but what's going on in your community. Again, the problem isn't just a problem of individuals, it's a problem of communities too. We know that 25% of high school age teens told us they could obtain access to a firearm off of their property in somebody else's home. They know where the firearms are in the community. And so your children, teens, go elsewhere to play. So as we think about how they interact and play with other folks and where they have access to firearms, thinking about both firearm access in the home but also firearm access in the community is important. So in terms of interventions that we can do, we know that healthcare-based locked storage counseling is an effective intervention. So families are largely receptive to discussing this when they come into the healthcare visits, as long as the provider does it in a way that respects their decision to own firearms and is informed by the science of firearm injury prevention. So it's important that it's not a message from a provider to a patient that says you shouldn't own firearms or you're not storing them in the right way, store them this way. It really needs to be done in a way that engages them in the discussion and discusses a range of options for storing firearms safely. And when it's done that way, it can be an effective method of counseling about firearm safety. And largely adults will make safer firearm decisions, and some will decide to remove firearms from their home altogether. And so it's important, and when we think about how we put those types of healthcare interventions into place, that we train our providers. Currently, there is no mandated training around this for healthcare providers. So one of the issues that we see is that they can't and are afraid to provide counseling on this topic for fear of alienating their patients, but also because they just don't know the technical basics of how you store a firearm. So one of the ways we've tried to address this is to develop some training modules around this for healthcare providers so that they learn about basic things about types of firearms, how you store a firearm safely, what does safe storage mean, what does locked storage mean, how do you provide that counseling that we were talking about to your patients that can be done in a respectful way. And this is one mechanism for increasing their knowledge and understanding of this. And I tell providers when I talk to them that, you know, you couldn't counsel somebody around how to put a car seat in a car without understanding how it works. You can't counsel somebody about how they store their firearms safely in a way that they're going to listen to you if you don't understand the basics of firearms. So that's sort of in the realm of locked storage. When we think about suicide and suicide risk, you know, a lot of what can be done at that individual level, one-on-one with healthcare providers in the exam room, is around limiting lethal means access. And what does that mean? That means that, you know, we know that most suicidal cases are relatively short-lived. And the method that somebody chooses to kill themselves really depends on availability. If a firearm is available, they will choose a firearm. It's the most lethal and quickest way to end a life. And we know that case fatality rates vary quite substantially across methods. If somebody tries to kill themselves with a firearm, they are almost universally fatal. So 90% of those don't make it to the emergency department for treatment. If somebody chooses to take medications, they're 1% fatal. So the differences there are substantial. And if we put time and space between a person and a firearm, we give them the time to get the help they need to treat the crisis that they're going through. And we know that from the data, folks who survive an initial firearm suicide attempt largely don't go on to have a second suicide attempt, and most of them don't attempt suicide again. So when we talk about counseling in this realm, what we're talking about is how do we enhance safety and storage in ways that that families will respect during high-risk crisis times, whether that's out-of-house storage, whether that's storage at a relative's house, whether that's storage within their own house but in a securely locked manner, so that an adolescent, a teen, whoever is going through a crisis event at that time, we reduce their risk and we reduce their ability to access firearms. I also like to point out that it's important that there isn't only one solution here when we talk about how do we do this type of counseling. It's really about tailoring those solutions to the situation that you're in. So I talked a little bit about adolescents and their risk for suicide outcomes and how we provide counseling around removing firearms from the home temporarily during that time period or making sure they're stored safely. But if we're talking about an older adult who's experiencing cognitive decline, the solutions are going to look different. They're going to need to be tailored. Maybe for that older adult, it's around, they have a proud tradition with owning and having firearms. In the initial phases of cognitive decline, they might be able to still have a firearm in the home, but maybe they only can access it with supervision by another family member. Or maybe we disable the firearm so it's not fatal, but they can keep the firearm in the home because it's an heirloom or it's an item that family values as an item for the home, but we make it less lethal by removing the firing pin or disabling the trigger mechanism, or not having live ammunition around. Maybe it's about transferring ownership, or at least having a plan to transfer ownership of that firearm to other family members, and we call that sort of a retirement plan for firearms. What does that look like in your family, in your household, for where firearms are going to go when you're not able to care for them anymore? And for some folks, it's about permanent removal of a firearm because they're at too elevated a risk. And so those solutions need to really be tailored to the situation in which we're providing that counseling. The other solution, similar to cars, we developed a whole bunch of engineering solutions for vehicles. We built safer cars. We have all kinds of technology in our cars now that we didn't have 30 years ago. We have technology that makes sure that we don't veer off the side of the road, that we know if a car's coming up in the lane behind us. So are there engineering solutions for firearms? Well, there are solutions out there, especially locked devices, locked safe storage devices, and smart guns that only allow the gun to be fired if somebody has the right watch or the right fingerprint technology. The problem with these types of engineering solutions is, one, they're not ubiquitous. Currently, they're not on the market for sale. There are some reasons behind that. Two, they're not largely accepted by firearm owners yet. And so the technology is not yet to a place where firearm owners are accepting that they will bring these devices in instead of the current firearms that they have. And so if we think about this as a potential solution, we have to think about how do we engage firearm owners in this discussion. What is the going to take to make people feel that these are acceptable devices to use in place of their current firearms? The other problems with engineering solutions at the present time are just the number of firearms that are currently in circulation, and having this type of technology go into the marketplace in a way that will really make a difference is going to take 15 to 30 to 50 years. And so this is a potential solution, but I think the solutions in this realm are not quite to the point yet where we have this as a strong tool in our toolbox. In the realm of interpersonal violence, we've seen that, and this is an area which I do a lot of work, we've seen that we can provide counseling within emergency department settings to youth who are at risk for escalation of lower level fighting into firearm violence, and that by providing that counseling and linkage to resources in the community, especially mental health resources and substance use resources, and counseling around how they address and deal with violent situations in nonviolent ways, we can reduce their involvement in future firearm violence for out to a year after that initial counseling. And so this is an effective tool, but it's not in every emergency department yet. It's not the standard of care that's provided. And so expanding on these and implementing these types of programs at a broader level throughout hospital and healthcare settings is really a key goal of researchers in this space. And identifying who's at risk. Our group actually developed something called the safety score, which is a screening tool that can be applied. All of you have probably gone to healthcare visits where you have to fill out a bunch of questions about different things, risk for depression, risk for other things. We've developed a similar score for who's at risk for firearm violence that we can apply in emergency department settings among higher risk youth populations, and identify who should be receiving these types of interventions. But again, these types of tools are developed in this scientific space, need to be expanded on and implemented broadly throughout healthcare settings. And then we need to figure out how we address higher risk kids who are further along the violence spectrum, who've already had a violent injury or who've already been engaged in firearm violence. A lot of the counseling interventions that we currently have that exist are really built more for lower risk teens. And so this is really an active area of research that people are are into right now is trying to figure out, how do we address that higher risk population before they land in the emergency department or the trauma bay. And then the other thing that is really important is, all the things I've talked about as solutions that we know have some evidence, scientific evidence behind them currently, have been things that we do at the individual level, one-on-one with folks. And we need to think about how we tie those in a broader sense to things that we can do at the community level. And we did a study actually in Flint, Michigan, where we looked at trying to deliver this type of package of interventions across all of these settings in one area, one neighborhood, in comparison to another neighborhood, and found that they could be effective reducing violence in the neighborhood and the community level. And so thinking about how we take some of these more individual level healthcare interventions and combine them with things we're doing in school settings and things we're doing with mentoring and fathers and improving relationships between fathers and sons, the things we're doing in communities around policing, and I'll talk a little bit about cleaning green initiatives, and taking the totality of those types of things and really investing in those and expanding on those in ways that will really have the ability to change the trajectory of violence that's going on in high-risk communities. And so we've seen that can work at a small scale. That needs to be taken to a much larger scale and implemented broadly. So a particularly promising initiative is around changing the built environment, changing the environment, again, sort of thinking about the physical environment that surrounds folks in some of these settings. You've probably all heard about the broken window theory, where one broken window in a community leads to multiple broken windows, leads to elevated rates of violent crime and other activities. Well, the alternative theory for how you address that problem is what we would call busy streets, which is if you clean up an area and you make it look more presentable and you take away what you're seeing on that left side picture and you make it look more like what's on the right, people will come out of their homes, they will engage in the neighborhood in ways, they will talk with each other, and what you'll see is decreases in violent crime, decreases in firearm crime, decreases in a whole host of other activities. And we've shown this in Flint, it's been shown in Philadelphia, it's been shown in a number of communities to be an effective strategy, especially in urban communities with elevated rates of violence. And so as we think about the totality of those solutions, again, and things we can do at the community level, thinking about how we can implement at a broader scale some of these types of interventions is really a key component of this. So moving out on that socio-ecological spectrum from the community to the public policy, how do we think about what's effective in this policy space and what can be achieved? And so, as we think about, there are really sort of two approaches here. One is preventing high-risk people from gaining access to firearms at high-risk times, kind of what I've been talking about all along. And the other is changing the bar at which legal firearm ownership occurs. And I'll just tell you at the outset, that second approach is not one that has gained much traction in terms of thinking about it. And so much of the focus in the public policy arena has really been around this first idea, which is how do we prevent higher risk people from gaining access to firearms at high risk times. And so a lot of this you've probably heard, especially in the news, but expanding background checks, having stricter background check enforcement has been shown in states that have this in place, have especially lower risk of intimate partner violence, lower risk of law enforcement being killed, lower risk of firearms being diverted from the legal market of firearms to an illegal market of firearms where people are purchasing them illegally on the back end. And when we've weakened background check laws in states, we've seen increased risks of violent crime. Similarly, domestic violence restraining orders have been a very powerful tool, especially when they have a firearm enhancement on them, which means that somebody who's under a domestic violence restraining order is not allowed to have access to a firearm. We've seen a significantly decreased risk of IPV homicide or intimate partner violence homicide due to firearms. A relatively new tool that's similar to a domestic violence restraining order but a little bit different is the extreme risk protection order, or what you've probably heard referred to as a red flag law. And the idea here is modeled after the domestic violence restraining order. If somebody is found to be at elevated risk for injuring either themselves or somebody else, family members, police officers, certain people can file for an extreme risk protection order where that person is temporarily not allowed to access, obtain firearms, or keep their current firearms. And the evidence base here is really still being developed, but in some of the states where we've seen this used broadly as a tool, we've seen reductions clearly in suicide. And there's still work going on to understand if there's parallel reductions in homicide or mass shootings. But this is really a powerful tool, one that's under consideration here in Michigan for potentially helping to intervene in a public policy way at those final stages. So a lot of the things I've talked about so far are really upstream prevention-based approaches to trying to address this problem. Extreme risk protection orders really are a tool at that last minute tool that can be applied when somebody's at really high risk and there's no way else to stop them from either injuring themselves or somebody else. And we know that in these school shootings and the shootings that we hear about every day, that there's often what's termed leakage, or the shooter is often told other people about their intention. And so this is a potentially powerful tool in which to reverse that trajectory and change those events. A couple others, so one, focused deterrence, which is often called hotspot policing or surveillance, has been shown to have reductions, especially in urban environments, in interpersonal violence and shootings. There have been a lot of implementation issues around how this is implemented and enforced, and concerns about disparity and equity. And so it's important that as we put in place policies, or we think about potential public policies, that we also think about the potential for the unintended consequences that result from those policies. And we measure those in a research way that can really determine whether or not the policy is acting as intended and not having consequences against specific populations. And then, preventing illegal firearm diversion. And so some of this, the universal background checks or permit purchasing laws have been a really powerful tool to limit diversion of firearms from the legal market to the illegal market. We know that a really small number of dealers are responsible for the majority of firearms that are eventually found to be in violent crimes, although that data from the Alcohol, Tobacco, Firearm Institute is not available for researchers to examine. So I'm going to use my final couple of minutes here to talk a little bit about what we're doing at the University of Michigan. And so we've recently launched, it's been about a year now, a little over a year, the Institute for Firearm Injury Prevention. And so I thought I would just give a little bit of an overview of that for folks to know sort of what's going on from the university here in town in this space. So I've talked a lot, I showed you those two curves, the motor vehicle crash curve, the firearm injury curve. And I said, we're way behind, that's a story as much about the failure of firearm injury prevention science as it is about the success of motor vehicle crash prevention science. The reasoning behind that is really because we haven't invested as a country in the research and the data that's necessary to understand this problem and to develop those solutions. And when you think about where you can see all of these medical and public health issues on this slide, where firearm injury investment from the federal government and through the NIH or the CDC or the National Institutes for Justice it really falls off the curve, and that we haven't invested as a nation in trying to develop these solutions. And really a legacy of the Dickey Amendment that was introduced in the mid-1990s. We've seen that start to change recently. So actually after Newtown shooting in 2012, there was really a move to start to think about how we could fund firearm research in a way that was not political again in this country, and that led to Congress really agreeing to start to fund firearm research in a real way. And while it's promising that we're funding it again at $25 million a year, that's really, when you think about how much money we spend on HIV and cancer and all these other issues that are really important, it's really a small amount by comparison. And to move the needle and build the field of researchers again, who we've lost over the past 25 years of not funding this, is really going to take a substantial investment and an increase in that investment. So the University of Michigan has been really a leader in this work for the past decade and a half, and has a number of investigators doing work across the university in different disciplines, using federal funding, using foundation funding to study this problem. And so as we thought about what to do in this space, because we have all this expertise that's been accumulated at the university, it was really to think about how we could coalesce that expertise in a single place and really have that be multidisciplinary and think about these problems from all these different angles and think about those solutions across the different regions of that Hayden matrix. How do we develop the capacity for new students and trainees and scientists to go into this space and expand that pipeline? And then how do we serve as a bridge and a resource between academia and communities who are impacted by this problem? And again, we take our lessons from the field of motor vehicle crash injury. So the University of Michigan, for those who don't know, has had a Transportation Research Institute for the past 50 years. And that institute has been part of the solutions that have been developed for motor vehicle crash injury prevention. And currently, if you go over to the institute, you'll see that there's a whole city that's been developed to test autonomous vehicles and to test other engineering solutions. And it's similar to other academic universities around the country to have institutes that are focused on this. And so as we think about what we need to do in in firearm injury prevention, I'd love to see the map not just look like Michigan here and a few other universities, but really to look like this map for transportation safety centers around the country, to look the same way for firearm injury. Because I think if we can do that, we can really move the needle on this problem. At the university, we've arranged ourselves to think about research and scholarship in this space, education and training, how we engage communities that are impacted by this problem, how do we improve the data and the rigor of the science that's done, and how does that data, rigor, science, research turn into effective policy and other programmatic solutions for the problem. And again, sort of going back to my first slide, we focus across all of these different types and domains of firearm injury. We have expertise in really a lot of these, and are building expertise in the other ones going forward. And while we are focused on efforts nationally and how we can influence the national spectrum, we also do a lot of work here in Michigan. And so this is just a smattering of the places that we're engaged in Michigan. We're working in the Upper Peninsula with firearm owners to think about locked storage. We're working at multiple hospital settings across the state to think about those interpersonal violence programs that we can put in place and whether or not they're effective. We're in more than 20 schools across the state, thinking about school-based programs to improve school climate and school safety and reduce the potential for school shootings, and are doing work in a number of other areas. And so as you start to think about how we're engaged from the university level in the community, you can see we're kind of spread all across Michigan. With that, I will end and I think take questions. There's some time for questions.
Thank you very much, Dr. Carter, for that presentation, which challenges us every day, it seems, to pay attention to. I should remind that the Zoom audience has been putting some questions in the Q&A function of Zoom, and please continue to do that. I've been looking at them as the presentation was going on. But also in the aisles, we have two microphone assistants, one on each side of the audience. And please put your questions on the 3x5 cards that are available and hand them over to the mic assistants. And I will be going back and forth between Zoom audience questions and questions here from the in-person audience. Jim, do you have one to begin?
Yes, I do. What fraction of all gun injuries is from defensive use of guns? Is there a valid argument for gun ownership?
So the honest answer to that is we don't have great estimates around that. So the estimates vary widely between some studies that suggest it's maybe in the neighborhood of about 100,000 defensive uses of firearm a year, to other studies that have said suggested it's as high as 3 million. The 3 million figure is pretty widely thought to not be true, and it's based on extrapolating from a number of small studies. So it's likely smaller than that. Exactly where that is, we don't know. What we do know is there is good data to suggest when somebody uses a firearm in a defensive manner, they're not really at risk, less risk for injury, that actually their risk for injury from a firearm in the event is actually much higher than other forms of defense in those episodes. And so we have seen that pretty clearly in the data. Certainly there are anecdotal stories and issues around defensive firearm use being a valid tool, But if we look at the data, there isn't a clear signal that that is protective in a way that I think some people advocate.
Bill, do you have one to offer?
Yes. Focus seems only on the human factor. How can guns be made safer, and can ammunition be made safer?
So I think there's a couple of things. So I think, there is the potential for an engineering solution to make guns safer. I think we're not where it's ideal to be at. I don't think the technology is 100% yet. And I think for firearm owners, in talking to firearm owners, I think for them to embrace that technology, it's really going to have to be fail-safe. And there's I come back to the parallels with motor vehicle crash injury. In the mid-1970s, there was an effort to develop seatbelt interlocks, which were basically a seatbelt that you couldn't start the car unless it was plugged in. And the problem was the technology failure rate for that was 0.001%, but 0.001% of people getting in their cars to go to work in the morning who couldn't start their vehicle led to a lot of discontent with seatbelt interlocks, and they failed to ever be taken up in a real way. And so the lesson learned there is the technology really has to be advanced, and we have to work with firearm owners in order to have them feel safe that it will be able to be used when they feel like they need to be able to use it for defensive reasons and protective reasons in order for it to really be taken up in a real way. And so I think there's some lessons learned from motor vehicle crash research that we can apply here. I think there are solutions in this space, but I think they will take time and money and investment to develop. I also think there's value in thinking about how you can enhance the use of those. So, for example, are there potential homeowners insurance discounts that can be provided in order for people to uptake those devices? Are there particular discounts that can be applied for people to purchase those devices and use them in their homes? In regards to ammunition, there is one tool that I think will be helpful, which is that there is now microstamping of bullets when they exit a firearm. And the advantage of that in new firearms is that it makes it easier for police officers and law enforcement to track down the perpetrators of firearm injuries. And so as we think about trying to clear homicide cases, which is a particular problem with firearms, that's an important component of the law enforcement end of this.
Jim, do you have another one?
Yes, I do. Is the increase in ISS, I forget what that stands for severity, due to bigger bullets or to more entry wounds? And I assume that's the automatic weapons.
So we think it's a combination of a couple of factors. So one, the changing nature of the caliber, the higher caliber weapons. Higher caliber weapons often also go along with the ability to have higher capacity clips, so also the ability to fire more bullets. And so that combination of just sort of more bullets and higher caliber causing more injury, but then also we're seeing that we're getting more people to healthcare settings because we have better EMS systems than we used to 30 years ago. And so we're seeing the more severe injuries that might have died on scene make it to the hospital setting. So it's a combination of both of those things that's likely driving that, although we don't have specifics on what the contribution is of those individual streams. And that's injury severity score, sorry. Yeah.
Bill?
I have one of my own.
Yeah.
People that store firearms and things, I would guess many people that live in high crime districts don't want to store them legally because they want access to them quickly. Do you talk to people about those kinds of problems? Because if I live in a high crime area, I might want to have it handy, even though I know I've had relatives to die from those kind of guns.
So there's a couple of factors there you bring up. So one, that refrain of the reason that somebody keeps their firearm out and not stored in a locked container because they want immediate access to it in case somebody breaks in the home. That's not exclusively an issue that we hear about from people who live in higher violent crime communities. That's universally across the board we hear that. So we hear that from firearm owners who live in communities that don't have elevated rates of violence, who've never had their home broken into, and don't fear crime in their community. And so when we think about how we address the solutions to this, some of it is about, talking about the risk, the comparative risk of, injury to somebody in the household who accesses that firearm versus, the potential that somebody's going to break in. So some of it's about that. And then some of it's about, are there other mechanisms in which we can store this firearm that allows you immediate access for those potential times when you might need it, but also keeps it not available to other people in the household. So that's where the idea of a smart lockbox or, a rapid access storage container that only the owner could access potentially becomes a viable option to suggest or to talk about in those settings.
Yeah, I'm going to turn now to some questions from the Zoom audience. I'll combine a couple here that are very much related to each other. You alluded to, I think, the improvement in focus and funding for research on firearm use. Could you talk a little bit about the impediments to getting to this point? That is, we had such a long time without the federal government, at least, doing funded research or funding it for people. Could you talk a little bit about that period of impediments, I'll call it?
So, as I sort of alluded to when I was talking, the Dickey Amendment was introduced in the mid-90s, and the idea of the Dickey Amendment was that folks who did research on firearms couldn't advocate for what was termed gun control in the Dickey Amendment. And while that didn't outright exclusively ban research on the topic, the federal agencies largely interpreted that as meaning that research couldn't be done in this space. And as I said, that led to this long period of time, this about 25, 30-year period, when people couldn't obtain federal funding for research to focus on this issue. And I think the shift really did begin to happen after 2012, after Newtown happened, when there was some initial federal funds diverted to sort of opening up the space, and then later the Congress appropriated funding specifically for firearm injury research. And I think part of what we, meaning we as the scientific community, had to do was to really focus on, the fact that we were doing research that was really meant to reduce injury and death, and it really wasn't focused on, sort of this idea that guns should be taken away from people who legally own them and operate them in legal ways. And so I think it's important to acknowledge, and I usually do this as I talk, that most people who own firearms keep them, store them safely, have them for hunting, target shooting, other reasons, and they live their whole lives with a safety and as an important component of how they manage their firearms, and are not a risk. And so we have to think about, as we develop these solutions and do the research in this space, how do we partner with firearm owners and not have it be antagonistic? And I think that was a part of the issue in the mid-90s, was the language that was being used to talk about this didn't have that inclusivity to it. And I would argue that if we think about the best injury prevention science, it's really done by partnering with people who are firearm owners, people who are at risk and at-risk communities, and having those communities help to engage in the solutions for the problem. I often talk about the analogy of pools. We don't tell people that they shouldn't be allowed to have a pool in their yard, despite the fact that there's a risk for drowning. We talk about how to keep that pool safer. We talk about putting a fence around it. We talk about training their kids to swim. We talk about flotation devices. We talk about parents being there and monitoring kids who are in the pool. And so the best injury science partners with people and uses them to help inform the development of the solutions to the problem. And so I think that Making sure that was the framework by which we approach this has been really critical as we think about obtaining federal funding again for this problem and the development of solutions in this space.
Well, there's one other one here from the audience, which I think is a good follow-up to that question, and that is, have the gun manufacturers been a voice in this debate? I suspect for sure they have, but I guess I would add a little bit to that question. Have the gun manufacturers on things like the technology solutions, have they really been engaged in that? Or have they stonewalled it, or what has been their attitude on the?
I think they haven't largely to date been engaged in that as a solution or to thinking about that as a potential solution. But I would liken that again to sort of where we were at the beginning stages of motor vehicle crash research. Car companies were not interested in seatbelts. They were not interested in safety. They were not interested in developing better technology. And now car companies manufacture on safety, and they manufacture and they market on safety. And so that was a 50-year change in the culture of how companies engaged on motor vehicle crash research. I think it's going to take, hopefully not quite as long, but I think it's going to take a similar effort to change that mindset some.
Yeah, sure, thanks. I'd just add briefly, sorry, Unsafe at Any Speed by Ralph Nader seemed to really trigger a lot of that, or Rachel Carson's book, Silent Spring, but I haven't seen a book quite like that.
There are some books out there. I mean, I think that it's, you know, it started the discussion. Certainly Ralph Nader's book Unsafe at Any Speed started that discussion. I think we're at a point where we're starting to have that discussion in a similar way, but I think the solutions took decades.
Yeah,
so.
sure. Let me turn back to the mic assistants. Jim?
Yes, this really gets to something that has all of us scratching our heads. I mean, we're unique in the Western world with this problem. I mean, they have hunters in other countries and swimming pools and all of the above. I'd like to read two questions because they're related. Can you address the mentality of the old Wild West in the U.S. that may contribute to people purchasing guns? And the second one is, what factors primarily make Americans uniquely protective of all gun ownership, apart from regular hunting and some pest management?
So I think culture is always an aspect of, culture and social norms are always an aspect of any of these health social issues. And I think thinking about how that influences both decisions to own firearms, which, you know, largely the number one reason people tell us they own firearms is for protection, and that feeling that you need to protect yourself even if you're in a community that is largely safe and doesn't have elevated rates of crime, is an aspect of how we approach the solutions to this problem. How do we partner with folks to understand that at a deeper level and have that help inform the solutions that get developed? And I think, you know, we're unique in that we are a country that has, you know, built into our Constitution this right to own firearms, you know, regardless of what you think about what the Second Amendment says or how it's interpreted, it's there. And so I think the solutions have to take that into account, and they have to involve those partnerships with firearm owners to think about how we solve this problem. It doesn't mean that the solutions that have been applied in other countries can't be applied here. It just means they have to think about them with regards to that social and fabric and social framework that we have.
Bill, do you have another one?
Can there be standardized national reporting of firearm death and injury? And a second question, should advertising of firearms come with warnings like cigarettes and alcohol?
It's a good question. So so all deaths do have to be reported. So that already exists. But the thing that doesn't exist are the non-fatal firearm injuries. I think we can do a much better job of collecting that data across the United States from hospitals. There is a movement at the CDC to improve the quality of that data and how that's collected. And so I think we will see that infrastructure over time get built out. So I think it's coming soon, but it's not quite there yet.
And that would be nationally?
That would be nationally, yep. So so they've funded research that's looked at how do we improve the collection of that data. The idea of that research will be that eventually, as we sort of figure out what the best model for that looks like, that it will be expanded nationally, but we're not there yet. That's again, we're behind where we should be because we haven't been able to do research in this space, so we're catching up, right? And then, the question of warning labels, is a good one, and I don't have a dedicated answer to that. I would say, in general, widespread public health messaging hasn't always been the most effective strategy. Whether or not it could be effective for firearms, I don't know. That hasn't been tested.
As a I don't own any firearms, so I've never bought one. But if I go into a store, no one ever warns me about the dangers of owning a gun.
So in general, no. I mean, you get a background check if you go.
I guess most people would know the dangers, they think, I guess. I don't know.
They do, but I don't know that they know necessarily all of the dangers, right? So we know that, for example, in the week after someone purchases a firearm, there's a higher risk of suicide. So thinking about how we develop interventions that can sort of address that risk is certainly an active area. The other area that I would say is really, again, needs partnerships with firearm owners is, when somebody buys a firearm, there's no standard training for how to use, operate, store that. There are some training courses from the NRA. They haven't been tested. We don't know if they're an effective educational strategy. What would be easy research to think about is what's the optimal way to train a new gun owner to have a firearm, own it safely, store it safely, and use it in the way that it was intended in a safe manner. And so if you think about, we have all kinds of trainings out there for all kinds of things, we could develop and test, and certainly this is an active area people would like to expand in terms of research. How do we train a new firearm owner around having a firearm? And the safety component is a key piece of that.
Okay, I'm going to go back to Zoom, and then I'll be back to the mic assistants again. Following up on something you just mentioned that's being developed in terms of record keeping. An audience member had already asked whether or not non-fatal injuries can be incorporated into the coding system. For example, diagnosis-related groups, DRGs, or ICDA. I'm not quite sure what the acronym is there. Could it be built into that when a physician treats someone in the emergency room or afterwards inpatient, so that would be easier to collect that it had something to do with firearms?
So it is built into the ICD coding in that there are ICD codes for firearm injuries. There's a couple of things we know about that. So one, and I'm a physician, so I can say this, we're notoriously bad at using the right ICD codes, and B, the intent. So a lot of the ICD codes are coded by intent, so self-inflicted injury versus an interpersonal violence related result. But we are also bad at determining in a healthcare setting intent and having that be correctly coded. So there's some errors in the coding, number one. And then number two, the issue really isn't about coding or identifying those at the hospital level. If you asked St. Joe's and the U of M to tell you how many firearm injuries they had every year, they could tell you that. But that data then doesn't make its way up to the CDC in any kind of real way. What the CDC does is right now they do probability samples, which this gets a little bit wonky, but basically they go out and they go to a bunch of different health systems and they ask them for their data on injury, and then they extrapolate that to what they think the entire United States is seeing. The problem with that data is that because firearm injuries occur sort of in uneven ways across different settings, what we're seeing is that that data is not super accurate. And so we need more widespread census data, which means we collect data from every hospital on this problem, and then we're able to tell exactly how many injuries are, rather than trying to extrapolate it from a small number, because then we get these sort of broad estimates that are really wide and aren't very specific.
Has the private health insurance industry stepped up and been interested in getting better data as they cover the costs of insured firearm victims?
You know, I think there's some interest in understanding how insurance can play a role, certainly, and but I think, you know, one of the things we as researchers need to do, and this is certainly an area we are actively engaged in, is in showing the benefit, right? So if we can show that, let's say, a counseling intervention that we develop and put in place decreases downstream costs as a result of injury, then insurers are going to get interested because it's less cost to their bottom line. And so that's part of the research that needs to get done too, is understanding at a cost level what the cost benefit is to some of these things that we think are valuable and evidence-based.
Thanks. Jim, do you have one?
Yeah, I'd like to follow up on the data collection. It seems to me that the data is already there in police departments and in hospitals. I mean, hospitals these days spend, what, 3/4 of their time recording data for the insurance companies. So what is the resistance to having a better national collection of data on gun-related injuries and deaths? What is it? Is it a political thing?
It's a monetary issue, right?
It's a monetary.
So to build that type of system, you're going to have to invest in that kind of system, right? So that doesn't exist right now. We operate, you know, states operate at individual levels. Healthcare systems operate individually. They don't tend to share data with each other on what types of patients they're seeing and whatnot. So there needs to be both a policy issue in terms of having healthcare systems have to report that data up, but then also investing in the system that needs to get created to collect that data.
Well, that's appalling, really. Oh.
Yep. Jim, or Bill, rather? Either
yeah,
one?
I've got more.
Okay, go ahead.
Yeah. What about licensing the purchase and/or use of ammunition by by caliber?
I don't think anybody's looked at that. So, you know, potential idea, I think there would face a lot of resistance around licensing ammunition. I think that would be a hard sell politically. Doesn't mean it shouldn't be tried, just I think that there's other, what I would call sort of lower hanging fruit that we can certainly do interventions on before you sort of get to that point. But.
And then also on this card, it has to do with what this one mentions, condominium boards addressing safe firearm storage, where you could have that regulation. But I guess I'd like to expand that. If the concentration of homicides is in cities, and if you have these apartments in cities, why couldn't you actually have a building code where you require that if you're building a new set of apartments, you have a gun safe in each one?
So, I mean, I think what would probably be more effective is a state-level policy around that. So, certainly you could have individual apartment buildings think about these types of things, but we do know that states that have child access prevention laws that are paired with felony conviction for accessing a firearm it's actually one of the policies that has the most effective evidence base for. So, I mean, as you know, there's a law under consideration here in Michigan around safe storage. You know, similar child access prevention laws around the country have been very effective tools at enhancing people's willingness to store firearms safely and as a deterrent for not storing it unsafely.
Yeah, I have another one from the Zoom audience. You alluded to it a little bit a while ago, but they're asking really, is the issue partly not effective messaging about firearm safety, unlike, say, what we developed for smoking cessation or vehicle safety? Have we just not developed the right messaging, or is it, you know, a small part of the problem as you see it in terms of how we talk about this issue?
Yeah, I mean, I think it's always, I think messaging is always an important component. I hate the term gun control because I think that it brings about this image of, you know, people taking away people's firearms. who might be owning them and having them legally. And so I really think it's about focusing on firearm safety and reducing injury and death. And I think when we think about that as the focus for the types of interventions that are needed, I think, people can start to have a discussion. I think when you see people talk about it from this angle of gun control, I think it stops the conversation totally. And so I do think messaging is important. I think it's an important component. I don't think it's the largest component. I think it's really about investing in, the data and investing in the research and figuring out what works and then implementing those things widely. But messaging is a part of implementing those things widely. So.
Yeah. Well, this next question seems to be getting into every conversation these days. Is there anything in the artificial intelligence realm that might be useful in considering reducing firearm violence?
Sure. There's always potential for new technology to have to influence the types of interventions and things that we develop. We're using artificial intelligence right now as a way to, in some of these violence interventions that we're doing, where we're applying multiple counseling sessions to figure out sort of how somebody's doing over time and whether we ramp up or ramp down the intensity of those interventions. And so there, I think, are a myriad of ways that we could think about artificial intelligence and artificial intelligence algorithms being a component of sort of the things that we do, exactly what that looks like. I don't think there's a single answer. I think it's a myriad of answers.
Sure. Yeah, I have one left from Zoom audience, but Jim, do you have one?
Okay.
Jim?
Would your work be easier if firearm use was broadly accepted as a public health issue and not an ideological identity issue? I'm thinking about the way Mothers Against Drunk Driving changed the cultural attitude towards drinking and driving, made the designated driver admired and okay. There are organizations against gun violence. How can they be used to contributing to the cause of gun safety?
So, I always think that, I always take the frame of this as a health and public health issue. So I think the answer to the first part of that is I think public health is the way to frame it. I think if you think about that broadly, that means everything from prevention to treatment to criminal justice. And so I think it spans that entire spectrum of solutions to this problem. And so that's sort of the answer to the first part. And then I often think about, where our role as researchers, and that's sort of my role as a researcher in this space, and where advocacy is. And I think they're distinct in some ways. I think that advocacy really is around how do you take what hopefully the researchers are showing you in terms of the data and the evidence base, and their job is to help move that forward with policymakers. And I think those are two distinct activities, and I think they both have value, and they're both extremely valuable parts of this discussion. And I think you alluded to, certainly for alcohol and drinking and driving, MAD was a force in terms of helping to move towards policy and solutions. But I think the research piece is what works, what will work in this space, and that's sort of our role and our job.
I've got one left.
Go ahead, Jim.
The person
Go
really
ahead.
loved your presentation. Thank you.
Oh,
On a personal level, what propelled you to get into this field?
Yeah, that's a great question. So I'm an emergency physician by training, so I work in an emergency department. I still see patients. It became very clear early on that once somebody ended up in the trauma bay from a firearm injury, there was not much I could do for them other than treat their wounds. And so my sort of motivation for getting into this is, as I think about how we approach this problem, a lot of what I thought needed to be done had to be done ahead of that event and that trauma bay visit. And so that's why I'm focused on what I am.
well, as we approach 11:30 and want to end, it's amazing we've gone all this time, an hour and a half, and I don't think the National Rifle Association, the NRA, one of the better known acronyms, they've had their own internal problems, as we've seen in the news, budget issues and embezzlement or whatever. But how do you see them at this point as having any role in partnering on this issue, speaking on it? Has that changed? Is it changing? What would you say?
I would say I haven't seen it change. I would say my hope and vision would be that they would be an active partner in helping to develop solutions in this space, because I think we can do more together than we can separately, but I haven't seen that yet. So.
Yeah. Well, the one last question that this came in says, how can we individually promote gun safety? I suppose people you know who have guns, encourage them to be safe, or that kind of thing? I mean,
Yeah, so I think, certainly as individuals, for those in the audience who are firearm owners, I think making sure that, you're locking up your firearms and keeping them safe is, step one. Step two is be advocates in your community for helping to solve these problems, and be advocates for the research, because I think we're not gonna make solutions to this problem until we invest in a real way in the research and the data and understanding what works and what doesn't work, and understanding the unintended consequences of things that we put into place. And so, be advocates for that, because I think that's the approach that will lead us out of the political quagmire and really focusing on the solutions.
well, at 11:30 and 12 seconds, thank you
12
very
seconds.
much
All
for
right.
your presentation.
Thank you so much for your attention.
Well, you